What's up, guys? Welcome back to my channel. Today I'm going to be going over a very crucial skill. It's important for all nurses to have, and that is TOA, Transfer of Accountability. Some people call it report, some people call it handover. It all refers to the same thing. So I'm currently located in Ontario. And my governing body is CNO, College of Nurses of Ontario. So I took the definition of TOA directly from their website, and I'm going to read it. And it says, your TOA involves the process of communicating client-specific information from one caregiver to another, or from one team of caregiver to another, to ensure continuity of care and client safety. Those are the most important things when we're thinking about TOA. TOA, providing report or handover, is a crucial component of the care transition process. So I am a hospital nurse, and TOA happens at the beginning of the shift or at the end of the shift, but not just at those two times. It also happens when a patient is, let's say, going down for surgery, or let's say the patient is being transferred from one unit to another, or even when you are going on break and you have to give report to your nurse who's going to be responsible for your patients while you are on break. So TOA is a very, very crucial skill, and the sooner you can refine this process, it will make your days so much easier. It will make handoff quicker, seamless, and especially if you're coming back in that night to have those same patients, it'll just make it a more seamless process. Before I get started, I did just want to say I've included a link below where you can download a free copy, free PDF of the report sheet that I use. I find that this is what's most effective. This is for my new nurses. It will take you some time to get into your own groove and to find what works for you. This is what's worked for me. Following this outline, I'm able to hit every system and to just ensure that I've given a clear and comprehensive picture of the patient that I'm handing over to the nurse. So again, I've included that link below so you can click it, download it, and hopefully it works for you. So at the very beginning, what do you want to say? I want to tell you the patient's name. What is this patient's name? What room are they in? What are they here for? So on a lot of report sheets, you'll see diagnosis. So you're not referring to every single diagnosis that this patient has in their chart. You're referring to what brought them here specifically. Did they have a fall? Are they here for a cabbage? What brings them here specifically? After that, you want to also include who is the attending physician. I call it MRP. That's what we refer to them at my hospital as. So who is the most responsible physician for this patient? So that's something you'll want to include as well. And what is their code status? Are they full code? Are they DNR? Are they A&D, meaning are they allow natural death but with treatment? Are they allow natural death with no intubation, with no ICU? These are all things that you need to include as well. After that, I move down and I include history. So as I mentioned before, a patient can have up to 20 diagnoses on their chart. You're not listing off every single diagnosis. You are just giving that nurse the diagnosis that is pertinent to that patient's stay in the hospital right now. So if this patient came in with falls and they have a history of dementia, that's something that I'm going to include because dementia and falls tend to go hand in hand together. And it's important for me to mention that in my TOA so that the nurse keeps an eye on that, because being cognitively impaired, that's going to increase your risk for falls. Same with if this patient has osteoporosis, if this patient had a hip replacement, this is all pertinent information to what brought them here today. So I'm going to be including that. After that, I'm going to be including any consults. Is this patient being followed by social work? Is OT following this patient? Physiotherapy, dietary? All of this is something that I would want to include. Was this patient seen by physio today and now they have been given the okay to be up with walker with supervision? That's something that I would want the nurse to know. I would also want to include any allergies. Is this patient allergic to codeine? Are they allergic to aspirin? Or do they have no known allergies? I have to include that as well. And so moving down, if this patient is on any IVs, do they have an IV running right now? Are they on IV antibiotics? Are we just bolusing fluids? If so, is it, or do they just have a saline lock in place? So just the saline lock capped off. And is it in the left arm? Is it in their right arm? Was this inserted earlier this afternoon at 4 p.m., patient has been complaining about pain to that site. I've been assessing, there's no signs of infection, but maybe you could just take another look at it and keep your eye on it, give medication for the pain, things like that. Moving down, I will be talking about skin. So you want to include any pertinent information to that patient's skin. Do they have any wounds? If they do have wounds, are they being dressed? So an example of this would be patient has a stage 2 pressure ulcer to their coccyx. I changed it today. The dressing is dry and intact. The order for that dressing is every 2 days. So that's information you want to include as well. And not only just any open wounds, just the nature of their skin. The patient has very frail skin, or patient is covered in bruises, hematomas. This is something that's very common with our elderly population. They have very, very sensitive skin. So sometimes that patient getting a simple injection can turn their whole arm purple. That's something that you would want to include as well. Does this patient have any drains? Do they have a JP drain? Do they have a chest tube and that is draining as well? That's something that you want to include. And moving over, I have a section for GU. How does this patient void? Are they continent? Are they incontinent? Do they get up to the bathroom? Are they continent, but sometimes they can be incontinent, especially at night? I have found that in my practice, especially with older adults. They may be continent during the day, but they're incontinent at night. So that's something I want to include. And then as a follow-up to that, I'm also including, patient wears briefs at night or patient has their own Depends that family brings in. You can include that as well. Or does the patient have a Foley? If they do have a Foley, when was it inserted? Is it draining well? Is it draining clear urine, or does it have sediments in it? These are things that you would want to include for that nurse to look out for. And just as a piggyback off of that, under the GU section, has this patient been retaining any urine? So I got this patient at 7:30 p.m. The patient may be incontinent, but I've changed their brief twice and it's been dry. Then you might be thinking this patient might be retaining urine. So I'll have to bladder scan them and see what's going on. And then if I bladder scan them and see that they are retaining urine, then you obtain your order for an in and out catheter. Or if the patient has a history of retaining urine, the doctor might order an order for a Foley catheterization. So moving over for GI, I will include, is the patient continent of their bowel movements? Are they incontinent? Do they get up to go to the bathroom? Do they prefer using the bedpan? Are they regular? Have they been complaining about constipation? Is there baseline constipation? And if so, do they get Senecot at night? I would include anything that has to do with the GI system here. So the patient has abdominal pain, has a history of abdominal pain, or every time patient takes their medication, they tend to complain of GI upset 30 minutes after. These are things that you want the nurse to know. So if he or she should encounter it, then they know, oh, okay, well, I know that you have a history of this, so let me administer the proper medications or act accordingly. Next, I include activity. So is this patient on activity as tolerated? Can they walk? Are they on permanent bed rest? If they are getting out of bed, how do they transfer? Are they a one-person minimum? Are they transferring with supervision by themselves? Or are they a max two-person assist? Do they get up via Hoyer lift, ceiling lift? Do they get up via Serosteti? Are they using any mechanical devices to get them out of bed? This is crucial information to have because you want that nurse to know this patient is getting up and this is how they get up. There's nothing worse than patient ringing to go to the bathroom or patient, I want to get out of bed, and you're thinking, I have no idea how you get up. You could ask the patient in that moment, how do you transfer? But in the cases where a patient may be cognitively impaired or may not be able to give you accurate information regarding how they transfer, then you got to go back, read the notes. You might consult the nurses working on the floor. Hey, have you had this patient? How do they transfer? So it's really important to include how that patient transfers. And I find that when you do include how that patient gets out of bed, that nurse is more likely to get them out of bed. And in the hospital, especially, getting out of bed every day can mean the world of difference. Sometimes these patients sit in bed for days at a time, and we know that this puts them at risk for everything, for skin breakdown. It affects their mood. It has a negative effect on their mental. It has a negative effect on their circulation as well. It compromises so many systems. So facilitating getting your patient out of bed can mean the world of difference. And that should include you giving TOA. That includes, how does this patient transfer? Moving on, I like to go over the cardiac and respiratory system. So for cardiac, I don't have too much experience myself with patients on tele, but if you did have a patient who was on tele monitoring, you're going to include this. Any pertinent information to the cardio system. So this patient on tele, did this patient have an EKG today? It came back abnormal or normal? Was this patient brought in for a cabbage and as a result, they're going down for an angiogram tomorrow? Any pertinent information to cardio, you're including that. Respiratory, I like to throw in here as well. So do they have any significant history regarding their respiratory system? Do they have a history of COPD? And because of that, they are taking inhalers. Do they have a history of COPD? And because of that, they experience shortness of breath on exertion. These are things that you want the nurse to know so that he or she can act accordingly. Was patient brought in for COVID, and because of that, their respiratory system is now compromised. And because of that, we see them on 2 to 3 liters oxygen continuous. Does patient have a hard time breathing when they're lying down? And because of that, I try and keep the head of the bed elevated as much as the patient can tolerate. So these are things that you want to include as well. Moving over, I do my neuro. I touch on my neuro system. Is this patient alert and oriented? If they are they oriented to person, place, and time? Are they oriented to their person only, so they can only tell you their name and they don't know where they are? And then to piggyback off of that, if you find that you tell them, Mrs. Smith, you're at Seattle Grace Hospital, are they easily redirected? Do they give you oh, yeah, that's right, that's right? Or are they saying, no, I'm not, I'm at home, or I'm at my daughter's house? So then that would prompt you to include this information that this patient is alert and oriented to person only, and it's difficult to reorient them. There is some confusion at baseline, information that you need to include. Also, can they follow directions? Are they pleasantly confused? Pleasantly confused meaning they might have, they might tell you, who are you? You tell them you're their nurse. And then, nurse, why am I here? You tell them why they're here. And then they say, oh, okay, okay, pleasantly confused. But do you tell them where they are? And like I said, they're giving you pushback. They're kind of agitated. Then you would include that as well. Patient has been agitated. Look out for this. And if so, you might have to consult the MRP to assess and order any appropriate medications, or if they do have appropriate medications, then you could administer that as well. Neuro is a very important system to always touch on. I've dealt with a lot of patients that have dementia. And with dementia, we see that patients tend to sundown around 2 p.m., 3 p.m. So that's when there's a marked change in their cognitive status. And this often involves them being one way during the day. And then as we move closer to the evening, they become another way. So I have found in my practice that the patients tend to be more alert, more oriented, more pleasant. They will accept treatment, they'll take their medications, but then as the nighttime comes closer, then that's where we see increased confusion, increased agitation, increased, them just not wanting to take their medications. So this is something that you need to include, especially if the nurse is coming on for night shift, then she needs to know that this patient tends to sundown. So you might notice that you might have to reapproach them multiple times for their medication. You should put the bed alarm on because patient tends to exit seek around 2 a.m., 3 a.m., things like that. Those are things you have to include. Moving on, I like to include a section about discharge. What is the plan for this patient? First of all, where is this patient from? Are they from home with family, from home with spouse? Are they from retirement home? And then piggybacking off of that, what is the discharge plan? Are they going to long-term care? Are they returning home with family, returning home with spouse? That is something that I like to include just to put on everyone's radar. Is the LIN involved? I'm in Ontario, so we have another governing body called the LIN, Local Health Integrated Network, and they would be responsible for facilitating, patients move from hospital to long-term care. So is the LIN involved in this? If so, then after you give that report, the nurse knows to go and check any documentation about this so that they know when they're giving report to the day shift tomorrow, they know, patients being discharged in 3 days, Lynn is involved. There are consults for OT, PT, so we can get the patient home or long-term care or back to the retirement home with appropriate aids, mobility aids. They might need a bar for their shower. OT would be involved and would facilitate that as well. So I always include the discharge information. And it just helps because sometimes you'll be on shift and your charge nurse will come up to you and say, what's the plan for this patient? And then I mean, you can always say, I'll take a look at that. There's nothing wrong with that either. But if you're able to say, oh, discharge back to long-term care as soon as patient reaches baseline, then it just is a more seamless process and you can keep it pushing. The last two things I like to include are labs and medication. Does this patient have any pertinent lab work that was taken today? Was this patient's potassium out of whack yesterday? We gave them a dose of K-Exalate, and now we reordered their potassium levels today, but it hasn't resulted for me. That means I have to let you know, keep an eye out for their lab results. And if their lab results come back critical, meaning that they're out of range, the potassium is still out of range, then that nurse knows I got to call the MRP and let them know and see what they want to do. Do they want to administer another dose of K-Exalate, or would they like to do something else? So you always want to include lab work that was taken. Does patient have blood work in the morning? If so, that's something that you can include so that nurse knows. The hospital I work with, we're so lucky to have phlebotomists. I thank God for them every day. They usually come around 7 o'clock in the morning. So if I tell that nurse patient has blood work in the morning, then that nurse knows, okay, I got to make sure that they have an armband on them. And I can let them know you have blood work in the morning. You can communicate that with your patient because sometimes we get busy, we forget to, and then lab shows up at 6 a.m., 7 a.m. I'm here to take your blood. And then the patient is confused. I already got blood work. I just got this yesterday. And then lab is looking for you saying patient is refusing blood work. It just turns into a whole event. So if you know patient's going for blood work, you can prepare that patient for blood work. For medications, I'm not including every medication that this patient is on. Sometimes you'll find that these patients are on a gang of medication. TOA should be clear, concise, and it should be efficient. So you could be giving TOA on 7 patients. You don't want to be just taking up unnecessary time. So I'm going to tell you the medications that the patient is on that is pertinent, that you need to know. So if I know that this patient has a history of Parkinson's, they're going to be taking Sinemet. I'm going to let you know patient is on scheduled Sinemet. And Sinemet, that particular medication, is time specific. So it's important that that patient gets that dose at the same time every day. So I'm not assuming that the nurse doesn't know this, but in me adding this in my TOA, he or she can put that on their radar and they can just have it in the back of their minds that, okay, patient has another scheduled dose of Sinemet at 7 p.m., just so I don't miss that dose. Is this patient on oral antibiotics? The same kind of rationale there. Antibiotics work best if they're taken at the same time. So I'm letting them know patient is taking Septra, next dose is at 10 p.m. They can put that on their radar as well. Are they on IV antibiotics? Same rationale. It's best if it's administered at the same time. They can put that on their radar. Patient has PRN puffers that they use. I find that they like to use them before bedtime. You can include that. Does patient have PRN medication for anxiety? So are they taking lorazepam that's not scheduled, but for the past 2 weeks, they've been taking it at nighttime? You want to include that in your handover so that the nurse knows that this patient likes to get their PRN lorazepam at night before they go to bed. And then lastly, I know I said those last 2 sections were my last, but this is the last section. I just have it titled Notes. And this is where I include any information that falls outside of any of the categories that I just listed. So under this section, I include, does patient have family? Patient has a daughter that's very involved in her care. Patient has family that visits from 8 a.m. to 8 p.m. Patient had a really good day today. Family came by and took them outside, or patient had a horrible day. They've been looking for housing and their application was denied. These are things that might not be clinical information, but these are things that help you paint a more comprehensive, a more holistic picture of your patient, and that will just help with the continuity of care, and that will help give a clear, concise picture of the patient. That is the name of the game. Clear and concise picture so that I can facilitate continuity of care and patient safety. Those are things that you should have in the back of your mind whenever you're giving TOA. Continuity of care and patient safety. What does this nurse need to know to ensure that the care that I've been giving continues? And what does this nurse needs to know to ensure that the care that they're giving facilitates patient safety? That is the name of the game, and that is why TOA is so important. So for my new nurses, like I said, it will take some time to find your groove, to develop what works for you. The template that I've included in my bio, like I said, it's what works for me. Something else will work for you. You might find that it's better for you to do your GU system first. You might want to do your MSK system last. It doesn't really matter which order you do it in, as long as you have a flow that works for you and that you're able to paint a clear picture of that patient. So guys, that is the end of the video. I hope you found this video useful. And I hope that if you did find it useful, you'll be using it in your TOA. I want to hear what you use in your TOA. What do you include? Do you have a template that you like to use? Comment down below. And as always, like and subscribe, and I will see you in the next video.